Good morning, ladies and gentlemen. So, welcome to this next session, which is sponsored by Involution. And the topic is on image guided PCR of distal left main stem disease. Perhaps if I can call, I'm Bruce Lee and anchor person, I can call the panelists to join me on stage Dr. Donny Firman, Dr. Upendra Kaur from India, Fazila Malik from Bangladesh. I think you can just stay on this side, Fazila. Kamaraj from Malaysia, Taufik Shahriar Haq, Ranjit Sharma from India, and Sunaria. Please do join me on board, on stage. Right. Any please, yes, thank you. So the session objectives for this is number one is to discover how coronary imaging can help in deciding on a strategy in complex distal left main stem disease. Second is to learn how imaging can help in optimizing the final results. And thirdly is to learn how stent clarity can be used to further guide final results. Essentially, we're going to have two complementary lectures. The first is a live in a box on managing or tackling a complex distal left main stem disease, and secondly, we will discuss on how the tools that we have right now can help us to improve managing or performing a complex PCI procedure. So, for the first, may I invite Dr. Fazila Malik to present her case in live in a box. So, Fazila, just stop us whenever that you want to discuss certain matters.
So, good morning, friends and colleagues. It's really an honor and a privilege for me to be here today. And today I'll be sharing with you a case of distal left main disease, which was image guided. And this is a live case in box. So please do ask questions, be as interactive as you want to be, and I can pause anytime you want because it's a live inbox. So without further ado, let's go to the case.
Once again, I encourage you to ask questions and go online to ask questions on the web.
Section.
We work at the National Heart Foundation Hospital and Research Institute, Dhaka, Bangladesh. And this is a 565-bedded tertiary cardiac care hospital, fully equipped with all modern cardiac tools. We happen to be a non-government, non-profit organization, and our aim is to provide the best possible cardiac care to our patients at an affordable cost. We started with a single cath lab in 1999. At present, we have 7 fully functioning cath labs, and last year we did almost 26,000 cath lab procedures. Of these procedures, 8,383 were PCI. We started doing left main PCI on a fairly regular basis since 2007, and the total number of left main PCI since then is 4,808. And in fact, last year we did 547 left main cases.
Our other team members who will be helping out in this case. So as I said, I'm Fazila. This is Dr. Abdul Qayyum. We have Morshed, our chief tech. And today we will be presenting a case of a 59-year-old gentleman. He's diabetic and hypertensive, and he noticed progressively worsening chest pain for the last few days. His pain did not subside even after maximal anti-anginal therapy. He got hospitalized and troponin was done quite a few times. There was no rise in his troponin levels. However, his pain was not subsiding and there were dynamic ECG changes. So he underwent an angiogram. And the angiogram revealed severe distal left main disease, trifurcating left main. The RCA was normal and did not have any significant lesion. So this is how his left side looks. And as you can appreciate, he has severe distal left main disease. The LCX is a smallish size vessel. The ostia is free of disease. So there's slight 60% stenosis in its proximal segment. The ramus is a large size vessel with significant disease starting from its ostia and extending for more than 10 millimeters in length. The LAD is significantly diseased, having 95 to 99% stenosis in its proximal end. And angiographically, we can notice quite a bit of calcium as well. So definitely a very complex disease.
You don't mind? Oops.
It goes back.
Oh, it goes back.
When I stop, it goes back.
All right. Okay.
Yeah, so we stop.
I think we'll just continue, then we can discuss. And then very start.
Friends and colleagues, it's our great pleasure to be with you in this type of sessions.
Yeah.
Now, we live.
What do you want to learn?
Yeah, just after this, yeah. That trying to get it. So, and the amp just stopped here, right? We stop here. And the okay, out. Okay. So we stop there, right?
Yeah.
The case.
I think just because this is the first part is going to be on a clinical basis on a complex PCI. Can I just ask? Welcome. You're from same hospital, so what are your thoughts on this? And it looks as if it's going to be a complex lesion. Is your primary target going to be left main LED and the OM or ramus, or is going to be the circ as well?
Definitely the target is going to left main LED, and then
Can you go?
take help from imaging and see how the other vessels look, and then we go at whether if we need we'll do a provisional stenting otherwise. But first target is left main LED.
All right. So it has been discussed that imaging is important, and is this something that you are doing on a regular basis? And what imaging technique are you using?
This is Medina classification 111. So this is upfront two stent strategy. So I'll go with two stent strategy.
Yeah. And that's going to be into the circumflex or the high OM?
I think the territory is larger with OM. That's why I'll protect OM.
All right. Your thoughts, Kamaraj, the same way?
Okay, I mean, when we were younger, we used to do a lot of bifurcation, etc., and all of that kind of stuff. But as we got older, we realized that single stent strategy is always the best, and we try our best to achieve that. So for me, first thing is left main into LED, and then the rest, of course, imaging will help. Imaging, we would use IVUS. I would not play around with an OCT or etc. like that with this kind of bifurcation mission. But of course, now we've got the additional usage of DCBs, which we use quite a lot. So osteal, the osteal OM, osteal ramus, etc., and all that can be treated with the DCB instead of putting in 2, 3, 4, 5, 6, 7 stent.
Okay. So, well, with regards to treatment, we can always expand a bit. But Donnie, you were saying that we were just in your session just now, and you were saying that if you're a Minister of Health, is this going to be mandatory to have an IVUS, and can a center that doesn't have, an imaging modality be performing cases like this?
Yes, this is the complex case and involving left main. So I think the use of imaging is class 1 in this particular, especially if you can see this is some calcification in the left main. So you have to precise to put a stent and to determine your strategy. So I believe the imaging is really, really important. It's a must in this particular.
So you think that's mandatory? Yeah? Sunaria, your thoughts?
It's a top fact. Decision after imaging is the most important.
Right. Upendra, 2 vessel, 2 lesions, 2 stent strategy.
Yeah, clearly is a complex lesion, left main multivessel disease. So obviously the LED is very, very tight. So I think first step I would do is to dilate it and then image it, because it might be a struggle to get in the eye with capture there. Do it and then image, and obviously if you don't have imaging, there are centers, at least in our country, who do left mains, then whatever we have learned from imaging, that means whatever you do, which angiography looks right, has to be upsized. If you have 3.5, go to 4. And even towards the ostium, come to 4.5 within the stent and get an optimal result between left main and LAD. And then you see what you're going to do to the other vessels. Cross, dilate, and then see whether you want to use a drug-eluting balloon, which is a good alternative. Or if you think there's a dissection and other things, you have to go in for a stent, then use a two-stent strategy.
Yeah. So there is a mixed group of having two-stent strategy versus, provisional, but it looks as if the circumflex does require to be treated, and high OM does require to be treated. Kamarachi, in view of perhaps just one stent strategy in using a DCB on the other hand. But it looks that 2 vessels at least needs to be done because they are definitely significant lesions and they're quite long. Fazila? Yep. Right, can we restart that?
That's what
Thanks.
the RC
was normal and did not have any significant lesion. So this is how his left side looks. And as you can appreciate, he has severe distal left main disease. The LCX is a smallish size vessel. The ostia is free of disease. How there's slight 60% stenosis in its proximal segment. The ramus is a large size vessel with significant disease starting from its ostia and extending for more than 10 millimeters in length. The LAD is significantly diseased, having 95 to 99% stenosis in its proximal end. And angiographically, we can notice quite a bit of calcium as well. So definitely a very complex disease, and it does fulfill the definition criteria. So what do we do here? Now, we need to see and reflect upon certain aspects of this disease. The distal left main is very significantly diseased as evidenced by the live QCA. And in the live QCA, we found that the distal left main had, can we have a look at the QCA, please?
Yeah. That's it.
92? So in the live QCA, we found that the distal left percent stenosis, very significant disease. And the LAD is also similarly diseased in its proximal segment, and it's also calcified angiographically. The ramus is a large size vessel, also having significant disease. And the LCX is a smallish vessel, and it's not, the ostia seems to be at least angiographically free of significant disease. So how do we go about treating this case? So first of all, we decided that in this situation, we needed to really focus on the LAD, the ramus, and the left main. And the LCX, we felt that we would be safe in leaving it alone. Now, this lesion, at least angiographically, we knew fulfilled the definition criteria of a complex left main disease. And so we wanted to opt for an upfront double stent technique here. And what we did is we opted for the DK crush. And here we focused on the distal left main LAD and the ramus. And we felt that the LAD and the ramus warranted our attention. So without further ado, we first wired the LAD, left main to LAD with our workhorse wire. We then wired the ramus with our workhorse wire, both being a run-through floppy wire. As this was an image-guided procedure and we felt that image would really help us in deciding what to do, how to tackle the lesion, we took our IVUS catheter. And our first run was from the left main to the LAD. And here, the great thing was that we had angio co-registration. And if you look at the angio co-registration, you can see that we have very, very significant disease in the LAD and the distal left main. It's quite calcified with the then went into the ramus with our catheter, and here we found that the calcium was actually quite heavily calcified as well. So both these vessels would need lesion preparation. So here we decided that we would be able to do quite a decent job with a NC scoring balloon. So that's what we took. We took a 2.75 by 10 NC scoring balloon, and we went up to 16 atmospheric pressure in both the first we did it in the LAD, and then we did it in the ramus. So we tried to do as decent a job of preparing our lesion with the NC scoring balloon. After this, we again took a Ribos catheter, and we saw that there was quite a bit of significant dissection in the left main, and we had managed to crack quite a bit of calcium in both the vessels, and we decided that our lesion was adequately prepared, and we focused on our stenting. So along with the DK Crush, first we took our stent from the so we took a 3x30 drug-eluting stent into the ram.
So the question is, would you agree, Upendra, let's start from you first, about the specialty balloon, or would you just use a non-compliant balloon or cutting balloon in this case?
Yeah, I think cutting balloon would be a good option in such a situation.
Yes. Yep. So you prefer cutting balloon rather than, and the reason being?
Reason being that it will stay at the same place, give it a nice bed, better than a plain balloon.
All right, because I think Fazila used a specialty balloon just now, which is a scoring balloon.
I use a scoring balloon.
Yeah,
Yeah, the scoring.
It's a scoring
principle.
which is I think looking at it, it looks definitely something
More trackable. It's more
from the
trackable
osteum
than
and
Wolverine. Yeah.
probably get a better end results. Do you think the vessel was appropriate, or you think that you would want to do further, especially with regards to left means?
Yeah, it seems the characteristic of the vessel is more fibrous than circular classification. So I think scoring the ink can well.
Yeah.
The size, matter. You use 2.5.
2.75 for the LED and for the, and also for the left main stem.
Yeah,
for the left stem. All right. So Fazila has gone on to stenting, and she felt that because of the cracks, and I presume because you find that cracks in the left main lesion, that the lesion you felt would be able to expand further upon putting the stent. Am I right?
And that was the idea.
All right. So, look, Fazila wanted to use of course, it looks at this, in this case, it will probably be appropriate to use the left main and to the LED as a main vessel, and to do a stent into the ramus in a sense. What's your choice, Donnie? Are you practicing the proper DK crush, or what people doing a mini crush, or even nano crush? What's your take on this? What's your practice?
If I have to do a two-step strategy in this particular lesion, maybe DK crush is my option, because the angulation is very ideal for DK actually. Though I find there's no much different in long-term outcome, even nano DK or any modification in long-term thing.
Yeah.
So get used to what you have to do. Get used to.
Yeah. But I presume the only thing about, if you want to call nano crush, the only concern that I will have is that you may actually miss the ostium. So you have to be sure that an ostium will not be missed. Come on, Rich, just a quick question from you. How do you do that? I mean, what's your practice first? Mini or?
I think I'll go for the standard.
Can you?
Sorry, I'll go for the standard DK crush because
So standard, you are going to bring back into the left main by how many mm?
maybe about into the left main, maybe about
4 to 5 mm.
Okay, and you believe that because of that, it doesn't really matter because left main is big and even a bit more metal.
Yeah.
So the classical, DK crush, just to ensure that you don't
don't miss anything.
Yeah. I think we'll go on first with and we'll carry on discussion afterwards. Yes, please.
Into the rammers, we took a balloon, a 3.5 by 15 balloon for the LED. Now, one thing in the DK crush that is crucial is that you need to put a balloon in the LED prior to deploying your stent in the side branch, because once the stent has been deployed, it will be impossible to take a balloon there to crush the stent. So this is something that we always need to remember when we do a DK crush, and that's what we did. So we deployed our stent, we pulled back the stent balloon, and then again went up to high pressure. After that, we removed the wire and the from the rammers, and then we crushed the proximal part of our stent with the balloon that we had positioned previously. We tried to do a thorough job of this with a 3.5 by 15, but nowadays it's customary to take even a larger size balloon subsequently and to do a quart so that you can really make a great crush, because crushing the proximal part of your deployed stent is crucial for further future rewiring, because if it's not properly crushed, there's always the risk that the wire may go abdominally. So we were quite happy with the crush that we did with a 3.5 by 15 millimeter NC balloon, because we went up to very high pressure. After that, after doing the crush, we wired the LCX, the rammers. We wired the rammers and we took a small balloon. The balloon went quite easily, and here you can see with the X-ray enhancement that we've managed to crush the proximal part. Maybe if we had taken a 4 millimeter, it would have been better crushed, but there you can appreciate that it has been crushed and our wire has gone through the proximal strut, and we are not abdominal. So we opened up the strut. After that, we went on to do our first case. And for the first case, it's customary to take small balloons which are sized according to the distal vessel. And here we took a 3 by 10 millimeter for the rammers and a 3.5 by 15 for the LED. Maybe we could have taken a shorter size balloon. We did sequential kissing. After that, we removed the wire from the rammers and we used it as a floating wire or as a cuspal wire to guide the position of our stent from the ostia of the left main into the LED. We took a 3.5 by 38 millimeter drug-eluting stent, which had the expansibility capacity to accommodate into the left main and also to be adequately sized according to the distal LED. We positioned our stent and then we deployed it. At this point, we removed our cuspal wire and we did proximal optimization with a 4 by 12 millimeter balloon, and we went up to very high pressure. We then took a wire and a microcatheter. Initially, we just took a wire and we rewired the rammers. And after that, we opened up the strut and then we did the second case. After the second case, we did post-dilatation of both the LCA, the rammers and the LED with the respective balloons that we used. And then we did report. After this, we took our, and then as you could see, the result was, and here we again did stent enhancement. And we could see that the stent looked, the stent was properly expanded. We then did IVUS. IVUS catheter again. We had angio co-registration. And if you look at the angio co-registration, you can see that
So as we go along, and you find that this presentation is not mainly about DK Crush step by step. It's not meant for it. But Fazila has done
So
a variation
now,
of the DK Crush. And what is important is actually to ensure that whatever results we got is actually very good. Yeah, Fazila.
the thing is, we are a bit concerned about the LCX. Even though this is not a very large sized vessel, we notice that there is some plaque shifting. However, the patient is hemodynamically stable. Now, do we want to take a third wire into the LCX and do tracing, or do something more complex like do a DCBO or something? So what we did is we wanted to evaluate whether this LCX was physiologically significant. And so we did a VFR, and we were very happy to find that the VFR came negative. It was 0.86. So we validated the fact that doing DK Crush was enough with the LAD and the LCX, and we did not, with the LAD and the Ramus, and the LCX can be managed as it is. We do not need to wire it or do open up the struts or use a DCB or anything. And this is the final angiographic view.
So, in conclusion, we would like to say that in this complex distal left main trifurcating disease, imaging and physiology really guided us. And our initial IVUS run, we saw that the MLA in the left main was only 4.6. After stenting, the MSA was 14.7.
On the LAD,
MLA was 2.08. After that, we found that after stenting, we managed to get it into 9.38. And in the Ramus also, the lesion was initially 1.78. After stenting, it became 5.78. So altogether, in this very complex case, imaging guided us, and we could obtain our optimal result. And not only imaging, also physiology allowed us to keep the LCX as it was. So overall, I think we're quite happy with the result that we got. And throughout the entire procedure, we used imaging to guide our decision making. Thank you.
Perfect. Beautiful results of a complex lesion, Fazila. Is there anything that you want to add on to what you've done, and just to emphasize once again about the case that you did?
right. So this was a fairly complex case, right? And it was angiographically also obvious that the lesion is very significant from left main to LAD. But we had live QCA, which is AI generated. So live QCA happens within a minute. So that helped us because it was integrated in the machine. So we could do live QCA, which gave us an idea about what extent of disease we had. And as there is angio co-registration with our IVUS machine, we could pinpoint the areas where we needed to address and also to get an idea what was the procedure result, what we achieved after a procedure. And the virtual FFR gave us an idea about the physiology, whether the lesions were significant or not. So all this came, so we used physiology, we used imaging, and we also used live QCA to give us the best possible result in a complex case.
I think you clearly showed that if you have the means, especially in treating complex left brainstem lesions, and you want to get absolutely optimal results, so that the long term and the short term results are good, and you don't have restenosis, and you have all this in just one angiogram machine, or
this was all integrated in one machine.
interesting. Any questions from the audience? Taufik? Yes, sir.
Just out of interest, after you prepared the lesion very well, there was some dissection in the left vein. Was there any hypotension or ongoing angina?
No, the patient tolerated that, so it was.
Yeah, I think even the section, as long as you got good flow, and the patient should be all right. Taufik, you are working in the same hospital anyway. How's your experience with it? I mean, the fact that, are you using it for all your complex cases, you think, or you're fighting with each other for the angio system that you have?
Actually, this new lab has everything integrated.
Yeah.
So definitely doing complex case in that is a different game altogether. But on the other labs, we tend to do imaging for the left main critical left main cases.
Yeah.
So
I suppose it's a good thing to have.
Multimodal approach for complex cases is always the best way to go.
Ranjit, do you have such system over?
I don't have a virtual FFR in my.
The virtual, well, no one actually, has, unless you've got the actual system. It's just that it looks as if it's quite easy to have everything on board.
Gives both anatomical and physiological assessment of cornea.
All right.
Compare with conventional,
Right. Okay. Fazila, thank you very much. I think this sets the stage. Please do come and join us. This sets the stage for what Upendra is going to present to us, at least to show, what is possible currently in cath lab, what you can expect perhaps in the future, and something related to AI, and not just AI, all the modalities that you would want to have, and you, in the end, I think in the future you should have, and trying to ensure that you plan your procedure very well, and also in the end assess the final results with all the modalities that is on board. Upendra?
good. So Fazila showed you a beautiful demonstration of a case in which some of the software which I'm going to talk about was also incorporated, giving you the QCA within seconds, within 2 seconds, not minutes, 2 seconds, to get all the measurements. Utilize them if you want to. You should believe in your eyes, do that. And then at the end of the procedure, get the results, do a co-registration, and also see the physiology without putting in a wire. You see the virtual FFR, and which was good. So anatomy as well as physiology tackled to your satisfaction. So now I'm going to talk about how artificial intelligence in our cath lab can make our lives easier without using repeated shots, and see how beautiful pictures you can make. Now this is the Sharp product portfolio, and you can see it has the artificial intelligence NST-QCA, artificial intelligence MAG, VFFR, which you just saw, and we also saw the integration of images by this Ivy Link. Now, this is the software which will give you within 2 seconds the complete contour of the vessel, lesion analysis, and also recommend the length and the diameter of the stent. And this is all, you don't have to put your cursor and bring in lines. It's all built in. You don't have to put in the catheter size and all that. Everything is just built in, so making your life simpler. And it has the FI score of 0.91 and accuracy almost 100%. Now, as you can see in this image, you can see this is the left main bifurcation, and you can see automatically this is being configured. You see the length, the diameter stenosis, proximal, distal, and also the stent length, which will be requiring according to this. Obviously, you have to individualize it and then see what you are satisfied with. And also the QC, as you can see, before you start the procedure and also at the end of the procedure, you get both of them simultaneously, and you can record them and also, see them for yourself. Now let us see the workflow of it. It just captures the complete length within a very short period of time, automatic frame recommendation. And then you get all the parameters of the whatever you need, length, the diameter stenosis, the distal vessel. Once again, very reliable and very accurate using this software. So that's how you get all the parameters without you working on it. Everything is automated and done for you. And it is reproducible. So everything done automatically, and it is also has an incorporated mag that you can magnify the image without choosing. Just have to choose one image, and then with a very good resolution, with a noise reduction, without any loss of the quality of the picture, you get it. It's based upon algorithm trained over more than 10,000 loops. It reduces the radiation exposure. As you can see, on the left extreme is what you see in our usual cath labs. And then higher magnified outputs you see on your screen, and you can see the beautiful pictures, very smooth, without any loss of the, image. There is no deterioration of the image. And as you can see, this is the mag 0, and this is the higher magnified outputs, and you can clearly see the lesion, the bifurcation, as I'll be showing. These are the higher magnified outputs with artificial intelligence mag, AI mag, which we call it. The clinical benefits, number one, there is no deterioration in the image. You can see the bifurcation, trifurcation, thrombus. If there's any inadvertent air injection, dissection, perforation, all magnified. And also the side branch analysis. As you can see there's the ostial stenosis in here, and you just have to go like this and you see the mag, and we confirm it very well that this is ostial, there's nothing in the LAD, left main is okay. So this is, one of the advantages, that you very clearly, confidently see what you're dealing with. You can see the trifurcation, you can see on the right side the mag part of it, and you don't have to do anything to magnify it, It's just, it's done by the machine, by the software. The trifurcation, very clearly, bifurcation, and this is beauty, air embolism, you see. You can see this magnified, and you can see how the air had gone in. Just a previous one. Yes. So you can trace the complete air bubble when you magnify it and see, confirm that you had injected air. Distal right coronary artery bifurcation seen very well. See the difference between the two pictures. Right, the magnified one makes it absolutely clear that the bifurcation is clean. Then the virtual fraction flow reserve, which Fazila showed in the case, very clearly you just have to take 2 images, and then the software draws it, colors it, color codes it. Green means the flow is normal, yellow means it intermediate, and if you see red, that means the FFR is going to be low there, and that is the portion which needs to be tackled. The 3D reconstruction from the 2D angiogram is created automatically. And this has been, supported by a number of clinical studies, which you all know very well, the FAST 1, the FAST 2, and the FAST 3 studies. This is the workflow video. Click on. Go back.
Good.
Yeah. We draw a contour for the first proximal end up the distal portion, distal part of the second artery, and then you can see, yeah, you get the color coding of it. This is what you also call by some other systems the QFR, is the equivalent of QFR. It calculates the VFFR value at every segment and tells you which segment has a flow problem where the flow is reduced. As you can see, the FFR here is 0.66 and higher up it was normal. So the features and benefits are that only 2 angiography views are required, the X-ray system independent, no pressure wire is required in this. You don't have to inject any hyperemic agents like adenosine and other things, and easy 1-minute analysis. Both pre and post stenting analysis is done. So this is the link which again Fazila's case showed that incorporated the angiographic image with the intravascular ultrasound or the OCT. You just need 2 angiograms, one with and one without contrast, and the image from your intravascular ultrasound or OCT, that's the intravascular image, and you can link the two. And as you can see, this is being co-registered, and by using this method, you get this complete co-registration, and you see this is the OCT image, and you can see the post-procedure result. So these benefits are that co-registered between angiogram and IVC, stent landing zone, as well as the zone where you want to keep the proximal edge. Only 2 views required, and this is cleared by many of the authorities like the FDA and the CE mark. Automatic co-registration is done. So I think these are some of the benefits which artificial intelligence can help you in the cath lab to get, quickly the result, verify it, confirm it, and do the procedure and be happy and sleep well after the procedure. Thank you.
Vendra, thank you very much.
Can I just ask a question? I'm
Yes,
quite
yes.
interested about this AI Mac, because after 14 years, all of us have lost our eyesight. So it's very interesting to see how clear the pictures look. So does that include, would that cause, or is it caused with extra radiation?
No, it does not. That is the beauty. No extra radiation. It is processed.
Okay,
Your image is post-processed,
okay.
magnified without losing any resolution.
I mean, this is what we normally tell our radiographers to, increase your penetration
right.
so that we can see, which means more radiation. So in this case, it is basically just
no
post-process.
extra radiation, no extra views.
And then the
Take
second,
one view, you magnify it.
the second question is, you're talking about co-registration, like for example, IVUS OCT. There are a lot of IVUS machines out there nowadays. So is all machines compatible to this so-called
Yeah, I
co-reg?
think this can be put in any machine. This software can be linked to any machine. You don't have to purchase a machine from the producer of this software. You can put it in. Like, Fazila showed, they have some other equipment and this was put in.
Thank you.
Here, thank you. I have one question. Is there any clinical conditions where BFFR cannot be performed? Is there any clinical condition like?
You mean the correlation between the invasive FFR and virtual FFR?
No, virtual FFR, like in aortosteal lesion, like in tarsus artery, we cannot do virtual FFR.
See, those limitations are going to be there.
Ah.
But wherever you can use the wire-induced FFR, which we have been using, ready system, and then it has been incorporated.
Like if
into the
clinic flow
the
is
same
less
thing
than
we will
3,
get.
we cannot do virtual FFR.
Yeah.
And in a thrombus also we can.
Yeah, and you don't have to be in the cath lab. You know, you've done your angiogram while you're sitting and deciding what to do on the post-processed image. We use this in 2 different views and you get the picture.
Whilst we are at the virtual FFR,
Yeah.
it's the same as QFR, isn't it? It's just that it's just that it's
QFR
just
is
on the
the,
machine
you know,
that in front of you, rather than you going out to the to the workstation outside and to do the QFR.
Exactly
And-
the same thing.
And you did say that it's only about 1 second.
1 minute.
1 minute. 1 minute. Or 1 second. 1 minute. That's quite fast. Anything on virtual? Any questions, ladies and gentlemen? Please, just come up. Something interesting. This is something that you think that is going to be for in the future, but it's actually possible to have it even right now. And I think there are a number of device companies that NG Systems are looking at it and working on it. Yes.
Yeah, in my opinion, in the near future, fellow in the cath lab learn much faster than the old days. Because in the old days, we sometimes used the day for diagnostic, and then we learn the case, and then we put the patient on the day of intervention. Now it's all ad hoc, and we did only 1 minute.
All right. Yeah.
Make decision.
Yeah, it's all about improving the procedure, management and the way that you do things, and it looks as if it's very promising.
Absolutely.
Any questions? I just want to ask you about the IV link. You were saying about IVUS and OCT. When you co-register the OCT, you need to inject contrast, and for the IVUS, do you still have to inject contrast, or you just pull back without? Contracts.
Yes.
Yeah. Fazila, you've got your.
No, for IVUS, you don't have to inject.
So you just
For the
angiogram and then you pull back and you watch it
Right.
but OCT you need the contrast. All right. Okay.
Well, I think life has become so simple. I remember when we started doing angioplasty.
Yeah.
Oh, that is way back. We used to hit the cine film. I don't know whether you remember those days. Develop the cine film, wait for that period, look at it, and after the result, you feel it's all good. And when the cine film comes, oh my God, I've left a dissection. So gone are those days. Everything is online, and now you can zoom it, and even small crack, you can magnify it and see how it is. So I think the artificial intelligence has become a part of us, and it has made our life very easy and simple in most instances. I think it can make it difficult also sometimes. Yes.
You did mention about the QCA, right? The AI QCA. Do you think that you can get away with most lesions just QCA, or you feel that intracoronary imaging is still important, or it has to be like together for a certain group of patients?
Yeah. Good. But see, the QCA with this software, it just, comes in a very short period of time. It has been verified that it is very reliable, but at the same time, it is the operator who has to decide whether to take this QCA or, take your own decision. Now, it will tell you 11 millimeter stent or 13 millimeter stent. It's not necessary that you put in a 13 only. No. You decide. After all, it is an individualized decision, but it helps you. In certainly, it helps you. All right. It makes you feel more confident and you're doing it more reliably.
Ladies and gentlemen, any questions? Fazila, you must be happy with your new position. Or you don't have to answer. that.
Rosli, can I have a question?
Yes.
Here.
Pratap. Here, go ahead. Yeah.
A diagnostic catheter and a guiding catheter, can it make a difference in the analysis? Because actually, most of the time when you do CTOs, what I see is actually, we may not see the septal collaterals very well in the diagnostic catheter. When you just see that, okay, I can do a retrograde after the guiding catheter. So sometimes your analysis by diagnostic catheter will be different. So even if you magnify a diagnostic catheter into 10 times, what you see that may be different from a guiding catheter because of the contrast injected into the coronary will be totally different. So this AI analyzed that thing or not?
I think it has not been separated out of it, But I think basically it takes the dimension of the catheter which you are using at the shaft level, at the level which is in the ascending aorta. It doesn't go to the tip, because it is the tip which is different in a diagnostic catheter and in a guiding catheter. So it takes the shaft into this and calculates all that. You don't have to feed in whether it is 6 French or 7 French. You just takes it and uses that as the standard and measures the vessels and their branches.
So Dan, you're buying 6 more cath labs? Are you thinking of acquiring one of this nature?
Maybe you can talk to Margarita. But I have some question.
Yeah.
Yesterday we have a live case with Dr. Howder from Sydney, and then there's a huge calcification of LAD, and the contrast not very well seen at the time, and then pressure wire should be down at the time. So regarding that, the calcification, huge calcification when the contrast not very well in filling. So do you think the AI will help? How accurate this system?
Yeah, I think it will help, but I think more work has to be done on this. These are some things which have just come in. And whenever you start these things, you go on a simpler situation. Calcification and other things as time goes on, then you will be seeing what are the discrepancies when the patient has a calcified vessel, mildly calcified versus a densely calcified vessel. Obviously, there are going to be errors, but all that has to be, built in, correcting factors put in, and then go it and then verify it. So it's a work in progress, I would say.
I mean, I'm not very savvy in all of this, but I believe that even with artificial intelligence, you need to have further iteration that it will learn better as time goes on. And I'm sure there's still some limitations with current AI to improve on itself, isn't it? So anything else that...
I think we're done.
Good. All right. So it takes me great pleasure to thank the 2 speakers. I think it's illuminating to understand that we now have, and we will look forward to having systems and built modalities that will help to improve our management or treating or doing our procedures in terms of pre-planning and also in terms of assessing results. And this includes the QCA, which we're actually doing, but most QCA are now done with eyeballing. But we're doing a lot more of imaging, and co-registration would definitely help, especially in terms of identifying where you're going to treat. And then the fact that there's also a virtual FFR. And the magnification, I think, in terms, so you want to magnify now, you magnify, you lose image, and it's very grainy, can't make out. And this is quite interesting that the iMac would give good results. If you have any need, there is a training village there's Involution outside booth, and then there's also others that you may want to consider and ask them about their technology. And of course, it gives me also great pleasure to thank the panelists and all of you for attending this session. Thank you very much, listen.